Hello guys, it's Dr. Manga here. So today I wanted to try and upload a video on treatment of thyroid ophthalmopathy, also known as Graves' orbitopathy. So first let's start by defining what Graves' orbitopathy is. By definition, it's an autoimmune retroocular disease. So the reason why it's called orbitopathy instead of ophthalmopathy is because this disease is primarily a disease of the orbit, hence the name Graves' orbitopathy. So there's an approach, guys, to treatment. First, you need to treat thyroidism, rather hyperthyroidism if present. And then secondly, you need for those patients who are smoking, they need to stop smoking, because smoking has been associated with worsening of inflammatory symptoms or unresponsiveness to anti-inflammatory drugs. And you also need to monitor and treat for hypothyroidism as a complication of medical therapy. And lastly, not last but not least, you need to treat using local lubricants to treat local symptoms. Lastly, you need to stage your patient and treat swelling and inflammation accordingly. So let's start by treatment of hyperthyroidism. So for treatment of patients with Graves' disease, you need to decide on the appropriate therapy to use. First, you need to control symptoms with beta blockers for every patient with hyperthyroidism and symptoms of hyperthyroidism, that is palpitations. You need to treat with beta blockers. And then secondly, you need to treat the thyroid levels. You can use either thionamides, that is carbimazole or methimazole, or radioactive iodine ablation. And the other option is thyroidectomy, which can be subtotal versus total thyroidectomy. So for patients with ophthalmopathy, you need to stage your patients whether they have whether they have mild, moderate, or severe symptoms. So for patients with moderate symptoms and above, you need to avoid use of thionamides. Use of radioactive iodine, because in comparison of these treatments, radioactive iodine has been associated with either worsening of orbital symptoms or new onset of symptoms compared to either thyroidectomy or thionamides, which have been shown not to have an effect on the ophthalmic symptoms. Also, like I said, patient with severe ocular symptoms, you need to use either thionamides or thyroidectomy plus beta blockers. Or if there's contraindication, you can go ahead and use radioactive iodine, but in that case you need to give them coverage with steroid therapy to avoid worsening of symptoms. Now moving on to local treatment. This one use mostly lubricants. You can use other lifestyle modifications like using sunglasses for protection if there's irritation or photophobia. And then the other issue, you can use methyl cellulose eye drops for those patients with irritation symptoms. And if your patient, maybe they have diplopia, you can use either eye patch or prism. Okay. Now moving on to treatment of orbital symptoms or treatment of inflammation and swelling. Like I said, you need to classify your patient, either they are mild, moderate, severe or side-threatening. So for patients who are mild, most of the time we don't use steroid therapy. We just use selenium. 100 micrograms for 6 months has been shown to improve symptoms of irritation. Although this has been studied in a relatively selenium deficiency population, European Thyroid Society recommends the use of selenium for 6 months. But other drugs that you can use include non-steroidal anti-inflammatory drug. Although they have not been studied, you can also use them. And for classifying whether your patient has a mild or moderate, you need to mostly it's clinical. You use the symptoms. For mild patients, they have symptoms of irritation, mostly response to local medications like lubricants. And then the proptosis is less than 3 millimeter of the upper limit of that particular population. And then most of the time they don't have diplopia. If they do have diplopia, it's intermittent. So in that case, you can treat using selenium or non-steroidal anti-inflammatory drugs. Then for those patients with mild to moderate to severe, I'm talking about patients with more than 3 millimeter proptosis above the upper limit, and then patient with diplopia, patient with corneal irritation. In that case, you need to use corticosteroid therapy. So you can use either oral versus IV. For oral, use 30 milligram prednisolone for 4 weeks. And then if you are going for IV, you use 500 milligrams of methylprednisolone from week 1 to week 6. And then after week 6, you can tap around to 260 milligrams from week 6 to week 12, giving a cumulative dose of 4.5 milligrams to 4.5 grams to 5 grams. Yeah. So after that, you assess your patient. For those patients who don't respond to initial therapy, you can increase the dose. And then comparing oral to IV steroid, IV has been associated with a good response and has been associated with fewer side effects compared to oral prednisolone. So those patients who have contraindications to steroid therapy, I'm talking about patient with steroid psychosis, patient with poorly controlled diabetes mellitus, or patient who the steroid therapy did not work, you can go ahead and step up the ladder to either rituximab, mycophenolate, or you can even use extraocular radiation therapy or decompression surgery, which takes us to the next step. For those patients with sight-threatening disease, I'm talking about patients with acute vision loss, which is usually preceded by loss of color vision. In this case, you need to start right away with steroid therapy. IV is preferred, and then you observe your patient. IV admission, you observe your patient for worsening of the symptoms. For those who have worsening of the symptoms, you go ahead and do surgical decompression therapy. So yeah, that is that about the topic. Thank you guys.